Today we have the pleasure of hearing from Dr. Rachel Vreeman, the Vice Chair for Research in the Department of Health System Design and Global Health and the Interim Director for the Arnhold Institute for Global Health. Dr. Vreeman received her MD from Michigan State University College of Medicine, completed her internship, residency, and chief residency in pediatrics at the Indiana University School of Medicine. Her research focuses on improving the provision of health care to children within resource-limited settings, focusing on supporting children's adherence to HIV therapy, disclosure of HIV status, and other HIV-related health behavioral challenges for children and adolescents in sub-Saharan Africa. Dr. Vreeman also chairs the Pediatric Working Group for the Global IDEA Consortium, a cohort with patient data from more than 1 million people living with HIV worldwide and funded by the National Institutes of Health. She has published widely and been the recipient of numerous awards. Please join me in welcoming Dr. Vreeman.
Good morning. As a pediatrician, it's always a little interesting to speak to a medicine audience, but I'm going to try to convince you and help you understand a particular population of patients that are going to be coming your way, while at the same time illuminating a bit about what global academic medical partnerships can look like. I wanted to start off with a story. This is Peter. So Peter is 16 years old, although he looks more like a 12-year-old, and he was born with HIV, but he wasn't diagnosed until he was 12 years old. His father died the year before he was diagnosed, probably of HIV, though no one knew that he was infected. And after an entire childhood of getting sick, one time after another, Peter was finally diagnosed when he was 12. He was diagnosed during a home testing campaign in Western Kenya, where his family lives. He was found to be HIV positive, and then he was enrolled in HIV care and immediately started on antiretroviral therapy through what's called the AMPATH program in Western Kenya. And through interviews and focus groups with children and adolescents and their caregivers in Kenya, we've learned a lot about what it means to grow up with HIV, particularly in low and middle income countries. And that's really what I'm going to capture in some of our research today. But I wanted to start off with a story, which is an excerpt from an interview with Peter. So Peter struggled to take his medicines for a number of reasons. These are his words about it. I was so bad with my medicines, I just didn't remember to take them. I love football, means soccer, and it's hard to remember to take medicines when you're busy playing football every day like I am. I wasn't trying to skip these medicines, they just did not seem important. I don't know why I was taking these medicines, I felt strong. But then I was missing too many medicines. I became sick and I had to go to the hospital. That's when I learned that I had HIV. It was a big shock to me. I thought this meant I would die. When I was released from the hospital, I just wanted to say that never happened. I don't have that disease. I thought HIV was only something that came to bad people. I was feeling better and thought it was some mistake. I think I was still in shock. I didn't believe anything like this could happen to me. I didn't take the medicines. I started to get sick again. I wasn't playing soccer much, and the other kids noticed I was too weak to play. They started talking about me and spread rumors about me, saying that I had that disease. I didn't like the medicines or to think about this virus, but I started hating being sick. There was a nurse at the clinic who helped me know about the medicines, and she introduced me to a group of other kids who were taking the medicines like me. It was easier to remember after that. I really felt stressed at school. I want to forget that I have this disease, but some of the other kids call me names. It helps me when we have time to talk together in groups at the clinic. It helps me remember that I'm not the only one, and I'm learning how to accept this disease. We actually have this story on a video, but it's in Swahili, so I thought it was probably easier if I read the translation for most of you. So Peter's story really captures some of these critical challenges that adolescents face after growing up with HIV. So first and foremost, we start to hear about the challenge of adherence. Obviously, antiretroviral therapy, the medicines for HIV, transform HIV from a terminal illness into a chronic disease that patients can live with. But without nearly perfect adherence, viral resistance can develop quite quickly, as well as opportunistic infections, more severe HIV disease, and of course, even death can result. And for adolescents, there are many, many issues that get in the way of their adherence. We also start to hear about how adolescents are wrestling through a period with the usual adolescent developmental tasks. They're trying to establish their autonomy. They push limits, they feel invulnerable, they don't want to be different from their peers, and they place a really high importance on what their peers think and seeming just like them. There's the issue of whether these adolescents are clinically fragile, as is the case for many of the children who are born with HIV and entering adolescence and adulthood after a lifetime of therapy already, versus whether they're asymptomatic, as is the case for more adolescents who are recently or behaviorally infected. HIV disclosure is an issue for many adolescents. Children who are born with HIV in many parts of the world are not told that they have HIV until they're significantly into adolescence. And delays in disclosure can hurt their adherence, and then wrestling with accepting this status creates further challenges for them. Behavioral and mental health issues are disproportionately common among youth who are living with HIV. Depression, anxiety, PTSD, and ADHD all occur at higher rates than in the rest of the population. Of course, there are significant social issues that many of them are wrestling with, which can shape adherence, shape their health behaviors, and this includes living in a context of HIV-related stigma, and then at the same time making their sexual debuts. And then there's a transition to adult care. In many places, adolescents are at a pivotal point in terms of where they're receiving care, whether they're treated like children or adults in those settings, but also the degree to which they're accepting responsibility for their own disease management. And then there's this question of building resilience. How do we help adolescents and young adults enter into a productive lifelong journey as they move further into adulthood? So my research work was really born out of stories like Peter's. My career as a clinical researcher has been primarily focused on the long-term challenges of children and adolescents growing up with HIV in East Africa particularly, but with a focus on the challenges of youth in sub-Saharan Africa. So I'm hoping to convey today what that looks like as this entire generation begins to enter adulthood. Oop, I went the wrong way. So before I talk about this generation of adolescents who are living with HIV, I want to tell you a little bit more about the place where I met Peter. So AMPATH stands for the Academic Model Providing Access to Healthcare. And AMPATH is a model of the power of an academic medical partnership in a global setting to really revolutionize access to healthcare. AMPATH is located in Western Kenya, and you'll see woven throughout the research that I'm presenting, as well as a further description, how that has been an incredible venue for not only providing access to HIV care, but broadly providing healthcare services across Western Kenya. In addition, I would argue that this kind of partnership provides a critical and incredibly valuable opportunity for education, as well as for research, which hopefully you'll see throughout the work that I'm presenting. The AMPATH program was started in Kenya from a long-standing partnership between Indiana University School of Medicine and the Moi University School of Medicine in Kenya. Before I came here to Mount Sinai this year, I was the director of research for the AMPATH Research Network while I was at Indiana University, where I directed the research program for their Center for Global Health. This partnership stems back to 1989, and out of this partnership between the medical schools, they launched a healthcare delivery system called AMPATH to really combat the HIV epidemic throughout the 2000s in Western Kenya. So I'll talk more about that as I go, but I wanted to help you understand a little bit of why it's been possible to do the kind of research work that I'm going to be presenting and answering questions for how we provide care for youth living in sub-Saharan Africa. So even as we think about how transformation in healthcare access and healthcare systems that support adolescents and young adults can make such change possible, it is important, I think, first to really consider, again, the reality of HIV today. It's easy right now for many of us to consider HIV as something that we've figured out, that we know what to do about. But the reality is that HIV is far from over for the world's young people. The medical advances that have transformed HIV treatment really have yet to alter the reality for young people in most parts of the world, particularly in sub-Saharan Africa, and especially in the low-income countries of sub-Saharan Africa, and for key populations of youth. While AIDS-related deaths for children have been cut in half since 2010, deaths for adolescents and young adults have only dropped by 5% during that period. So HIV continues to be a massive challenge for the health of young people worldwide. Thinking about the global HIV epidemic for a moment, to review our big numbers, 75 million people have been infected with HIV worldwide. They estimate that currently 38 million people are living with HIV. We've had about 32 million deaths from HIV that we know of. And the numbers of deaths for HIV per year still get close to 1 million deaths per year. Last year's estimate was 770,000 deaths, which is the first time it's dropped under 1 million in the UNAIDS estimates. And we have similar estimates, of course, for children living with HIV, which are this generation that's coming forward into adulthood. Last year's estimate was that there were 1.8 million children 14 years of age and under who are living with HIV globally, and only just under half of these children are on ART. So children's access to HIV treatment continues to lag significantly behind adults. Interestingly, from an epidemiologic perspective, and for those of us who are thinking all the time about children who are living with HIV, we've had major changes in the numbers of children estimated to be living with HIV globally, which is an area in which my own research work has been significantly involved. Before 2017, this number was always estimated at over 3 million children living with HIV. But in 2017, a data consortium that I'm part of that I'll describe further called the IDEA Consortium began to contribute actual patient data into the pediatric estimates and the modeling system that's called Spectrum that UNAIDS was using to create these critical estimates every year. And when we put in actual patient data, we realized that children were not starting on ART at young ages at the rates that that had been modeled, that had previously been expected. And this meant that more children were dying young. And so when we look at the numbers, there was suddenly this huge drop in what was being estimated because we realized that in actuality, there were many fewer children living with HIV. They weren't surviving to be going further into childhood. So this is a case where in our epidemiology, a significant drop in our numbers by more than 1 million children living with HIV was actually terrible news when we looked at the clinical data and what was happening with this, as opposed to what was being estimated before. For adolescents, it's an interesting picture as we think about what happens for these children who are growing up, who are moving into adulthood with HIV. So despite the massive increases in ART access worldwide, HIV remains the leading cause of death among adolescents ages 10 to 19 years in sub-Saharan Africa. They estimate that there are 1.8 million adolescents living with HIV globally. This is, again, 10 to 19-year-olds. And 80% of those adolescents are in sub-Saharan Africa. Older adolescents, those who are 15 to 19 years, are the only age group where there's increasing HIV mortality currently. Mortality is declining in all other age groups that you parse out, but older adolescents still have increasing mortality every year. Between 2000 and 2015, the adolescent AIDS-related deaths more than doubled in the 25 countries with almost 90% of the world's adolescents who are living with HIV. And in sub-Saharan Africa, we still see 36,000 adolescent HIV deaths per year. So all of these big and really terrible numbers are to emphasize that this is still a very active and very tragic epidemic for the world's adolescents in particular, and it's dramatically shaping the landscape for the generation of young adults that are coming forward. This is a quote from Michael Sidabi, the UNAIDS executive director, which I think really captures part of this as well. He says, AIDS-related deaths are rising among only one population group, and that is young people. We will fail to achieve the end of AIDS if national policies and practices continue to restrict young people's access to HIV, sexual, and reproductive health services. We must tackle the determinants of HIV risk and vulnerability and facilitate the realization of young people's rights so that they can achieve their full potential in life. So in many ways, this high adolescent HIV mortality reflects numerous critical gaps in the HIV care cascade, which I'm going to talk through more today. This includes very low rates of retention in HIV care and complex challenges for adherence to antiretroviral therapy. Adding to these complications, our adolescents, of course, are going through significant physiologic and psychosocial changes that make them particularly vulnerable on top of these care challenges. And all of these changes continue to impact their outcomes well into young adulthood and beyond, especially as we look at our 20 to 24-year-olds. This is a summary of the HIV care continuum, which is how we try to capture the series of steps that a person with HIV takes from the time they're initially diagnosed with HIV through what we hope will be their successful treatment with HIV medication. So in these steps, you're initially diagnosed with HIV. We hope that you're linked to care, you're then engaged or retained in care, you're prescribed antiretroviral therapy as part of that care process, and then you achieve viral suppression. With viral suppression, not only do you have the ability to potentially live a long life with, in many settings now, equal life expectancy to people who are living without HIV, but it also means that if you're able to maintain undetectable viral loads, that you are you are not going to transmit HIV. So we really can achieve a lot if we can move patients successfully and support them through this care continuum. In the HIV world, we often hear about the 90-90-90 goals. These are goals set that you would have 90% of the people living with HIV diagnosed with HIV worldwide, that 90% of them would be prescribed antiretroviral therapy, and that of those, 90% would achieve viral suppression. Of course, getting 100% instead of these 90s would be terrific, but we've set targets for reaching 90-90-90 across our care systems in multiple countries. I'm going to talk a bit about the IDEA consortium because it's a global epidemiology data consortium that gives us some of the best data we have about how we're doing for adolescents worldwide in meeting these 90-90 goals. So one of the most exciting opportunities that I've had as a clinician researcher has been to join and collaborate with the IDEA consortium. IDEA stands for the International Epidemiology Databases to Evaluate AIDS, and this is an international research consortium that was established in 2006 by the National Institute of Allergy and Infectious Diseases, which subsequently has been supported since then in years from multiple institutes of the NIH. Much of the work that I helped to support in this consortium, because I'm a pediatrician and because of what we're doing, is supported also through NICHD and NIMH, but the National Cancer Institute and others are also equally involved with this now. IDEA provides a rich resource for global data about the HIV epidemic. It includes 7 global regions that you can see mapped out there, including West Africa, Central Africa, East Africa, Southern Africa, North America, a combined region that includes the Caribbean, Central America, and South America, and then Asia Pacific. So I said it's a research consortium that's funded by the NIH, but what it does is it compiles data from a network of HIV care delivery programs. Some of these programs carry out research work, but the majority are primarily clinically based programs that have been have had infrastructure supported to be able to contribute data into these really large data sets globally that then can be used to address high priority research questions and try to streamline HIV/AIDS research. It's been my privilege to chair the Pediatric Global Working Group for the IDEA Consortium since 2015, trying to look at these pediatric and adolescent data worldwide and figure out how we can answer some of these critical questions for what it takes to really support the world's children and adolescents in moving forward into adulthood, when we hope to hand them off to all of you, essentially. So what does the HIV care cascade for global adolescents look like? Again, these are there's some key answers for understanding how they are according to that care continuum. So one of the first things that we're able to look at, I should note, within the IDEA consortium, we don't have a great, because we're working with data from HIV care programs, our answers for how many adolescents and children are being diagnosed with HIV are less clear. But starting with once they're diagnosed, we're able to look at the rest of this care continuum going forward. So thinking about antiretroviral initiation, in an analysis that we did looking at over 115,000 children in global IDEA, our adolescents, particularly those ages 15 through 19 years, as well as our youngest babies in this, had the lowest ART initiation rates. Adolescents were at 54.3% initiation of ART. Compared to adults, adolescents have more ART non-adherence, they have more viral non-suppression, and they have increased morbidity, death, and HIV transmission. I'm going to walk through each of these. Rather than filling the screen with references, I have a link where there's a whole bunch of references for all of these statements there to try to keep things a little bit simpler. So if you're particularly interested in research on this, feel free to copy that down and refer to it. So thinking about how they have more non-adherence. So adolescents actually have worse adherence than younger children and worse adherence than adults. And evidence worldwide suggests that they're failing to achieve and maintain the adherence that they need to prevent viral resistance from developing. Now, in systematic reviews, we actually see suggestions that children, adolescents, and adults in low and middle income countries have higher rates of ART adherence compared to those in high income countries. But in most of these settings, adherence is typically measured through self-reports or through caregiver reports of adherence, which are probably not capturing the full extent of non-adherence. People tend to report overall on very simple, straightforward measures that they're doing fine with their medicines, even if that's not really the case. And resource-limited settings especially seldom have the opportunity to dig deeper into how their patients are doing with that with things like drug level monitoring and so on. However, we have been able to look at medication adherence more in depth, and particularly the team that I've helped to lead in East Africa has done a lot of work to measure medication adherence and try to validate strategies for how we might measure medication adherence even in really resource-limited global settings. So to look at adherence beyond what our adolescents and our caregivers are reporting on when we encounter them clinically, just in a quick ask of, are you missing any medications? How are you doing with your adherence? We've moved to try to use some more novel methods to measure their adherence and to look at the implications of that. So in our setting in Kenya, we've been able to use both plasma drug levels as well as giving patients electronic dose monitors that record electronically when their medication bottles are being opened to look at their adherence. We then have been able to compare their dose timing information and their plasma drug levels with their reports of adherence on questionnaire items to figure out which questions work well, what we should be asking, and how we can get a better sense at who's having the kinds of problems with their medicines that lead to resistance later on. So across multiple global settings, what our research teams have ended up using have been a specific kind of electronic dose timing monitor called a MEMS cap, or a medication event monitor. The mother with a little girl there is holding a bottle that has the MEMS cap on top of it. This happens to be an enormous bottle in this picture because this little girl was still on liquid formulations of medicine. And if you're taking a liquid medicine every day for a month, you need to have a lot of it. So we have to use really big bottles for our younger children. Our adults, thankfully, can use somewhat smaller bottles. But essentially, this is how we use it. Our patients have their medicines in these bottles with the special caps. When they come into the clinic, our research team takes the bottle cap, as you see there. They download the information on the dose timing, and it creates a graphical readout of how they're doing with their medicines. Ideally, we'd like to see a picture like the one on the top, where a dot that represents every medication opening is so close together in time that it looks like a straight line, periodically showing their once-a-month visit where They come in for a study check and we open their bottle at a different time of day. Unfortunately, many more of our patients have readouts that look like the one on the bottom, where you have gaps in medication taking and the time is a bit more scattered. So what have we been able to learn about children's adherence to medications with some of these strategies? So across several subsequent Kenyan-based pediatric adherence measurement studies, we found in total that only about 50% of children and adolescents were achieving our goal of taking more than 90% of their doses on time. And this is something that goes up as they're followed with the medication events monitoring, because that's something that we do openly with them and show the adherence monitoring. But still, we see only about a third of them being able to maintain greater than 90% MEMS adherence over 6 months of monitoring in several subsequent studies. Treatment interruptions of greater than 48 hours are also common for children and adolescents. About half of the patients have at least one. And we typically see a median of 3 treatment interruptions per child or adolescent in our 6-month study evaluations. We also find consistently across these studies that older age is significantly associated with more non-adherence. And by this, I mean older age, mean those who are older than 10 years and less than 19 in the 10 to 18-year-old range. Now, out of this work, we were able to identify 9 adherence questionnaire items that correlated most closely with MEMS adherence, with plasma drug concentrations, and also with patients' viral loads. So we used that to create a relatively short form questionnaire that was then subsequently validated in multiple settings in Kenya, and then in a global validation trial that included sites in East Africa, South Africa, and Thailand. Looking again at the results from this study, because of what it shows us in terms of how adherence is going for adolescents, we see that when we look again at our benchmark for MEMS adherence or opening bottles on time of greater than 90%, we see that about 57% in Thailand, 58% in South Africa, and 40% in Kenya and Uganda were able to achieve this. So between 40 and 60% of our patients are able to at least open their bottle enough to potentially have doses at greater than 90% of the times when we would want them to. So that's a lot of non-adherence. Again, our adolescents have more non-adherence than younger children across each of these settings and across each of the studies. Now, we also see less viral suppression for adolescents compared to adults, again, as I said. Unfortunately, our global viral load data are still quite sparse for adolescents in resource-limited settings. It's really only been in the last 2 years that particularly within our sub-Saharan Africa HIV care programs, that sites have been able to offer any sort of routine viral load monitoring. So these data still are primarily from larger programs that have more ability to do viral load monitoring. But looking at, again, some of the global data that does exist, the CIPHER cohort is an additional pediatric HIV research consortium that includes the IDEA data consortium that I was talking about, as well as a European cohort, the PENTA cohort, and a North American cohort called the IMPACT cohort, added into the data. For this cohort, we were able to put together data for 38,187 adolescents ages 10 to 19 years for whom we had viral load monitoring data for at least a percentage of them. Of those adolescents at age 10 years, so entering adolescence, 68% were virally suppressed, and at their most recent visit, 69% were suppressed. So we didn't see for that cohort big drops in their viral suppression across adolescents. However, it was a much smaller group that had viral load monitoring, and still having 70% viral suppression is much lower than we would like to see. Again, our goal being 90 to 100% viral suppression among our patients. The joint UN program on HIV in their global sampling found only 27% of 9 to 19-year-olds were achieving viral suppression, compared to 63% of young adults of 20 to 29-year-olds. And adolescents had a significantly higher risk of virologic failure. Of course, as one would guess, going along with poor adherence and low rates of viral suppression, we start to see lots of resistance in this age group as well. Now, resistance patterns and development for adults have been fairly well understood for quite a while, but shockingly few data are available about this for children and adolescents, particularly on the current regimens that we see being used worldwide. In our setting in Kenya, where I work, my research team has an ongoing adherence and resistance cohort with children and adolescents that we've now been following since 2008. Most of them started in the cohort when they were less than 13, and they're almost all adolescents now. Thanks to several rounds of subsequent R01 funding that we've had for this, we've been able to follow to start to really look at their resistance development with more specific resistance genotyping and phenotyping to answer some of these critical questions that are existing about how children and adolescents develop or don't develop, ideally, resistance to their antiretroviral therapy. But essentially, the picture is really bad for their resistance. In our group of 227 children and adolescents for whom we have the most detailed data stemming back to 2008, 32% had treatment failures. They had viral loads greater than 1,000 copies. About 40% had adherence that was less than 90%. 40% roughly also had treatment interruptions of greater than 48 hours. And matching pretty closely with that, about 50% of their caregivers reported some form of non-adherence on questionnaire measures, the questionnaire that we developed in this setting, which they received monthly assessments with as well. Treatment failure was significantly associated with the lower MEMS adherence, not surprisingly, in this group with younger age, with less time on ART, with lower CD4 percentage, with treatment interruptions, and with low nevirapine drug levels. When we did genotyping for those who had ART failure, 81% had intermediate to high resistance to more than one drug, 100% had high resistance to their current ART, and 75% had resistance to potential second-line options for their medicines. So lots and lots of resistance, and we have some more specific resistance typing results that we're just starting to present and writing up. Thinking further across that care continuum for adolescents, we know that adolescents also have worse clinic engagement than younger children or than adults. They have a higher risk of being lost to clinic follow-up. And there have been relatively few studies that look closely at why and how adolescents disengage from care and then re-engage from care, that we see frequently in this age group kind of stepping back from care for various reasons and then coming back and going back and forth. We don't know whether these engagement patterns or how they change over the transition to adulthood. No one has really looked at that yet. And we also struggle with how our health services can better support care engagement for adolescents. Looking at this issue of clinic engagement has been a question of great interest for the Global IDEA cohorts. Looking at about 60,000 adolescents from 34 of the countries, we saw that about 4% of them die between the ages of 10 to 19. 30% were lost to follow-up during adolescence, and 8% of them transferred out of care. We see higher risks of loss to follow-up among females, among those who started treatment a bit later at ages greater than 5 years, and among those who are in more rural settings. Some of the regions specifically have looked at this further. In East Africa IDEA, the older adolescents experienced the highest rate of loss to follow-up, approaching 50% of them being lost to follow-up within the 2 years that they examined, and also this group had the lowest ART initiation rates at 20%. In Southern Africa, they found that the risk of loss to follow-up increased as you moved from younger adolescents to older adolescents to young adults. And we also see across these studies more loss to follow-ups during transitions from pediatric to adult services. So essentially the picture is bad for adolescents and then gets worse when they transition to adult services in that way. And I guess sort of the worst data of all, as I mentioned, HIV is still the top cause of death for adolescents in sub-Saharan Africa in particular. Worldwide, we estimate that we have close to 60,000 deaths. We looked across, and if you look across the regions, the first number is referring to deaths in adolescents who are 10 to 14 years of age, and then the second number is deaths in adolescents who are 15 to 19 years of age. So you can see in each of these regions the really significant numbers of those older adolescents, the 15 to 19-year-olds who are still dying annually. How else do these children look? A few more characteristics that are slightly outside of the care continuum that I was focusing on. So these adolescents also tend to be stunted. They're across the board smaller than their uninfected peers, and we see differences in their growth velocity over time. In an analysis that we actually just had published last week from the Global Idea Group, looking at almost 9,000 adolescents across the global regions that were with their data between 2003 and 2016, found that 41% of them were stunted at ART initiation already. And interestingly, there were some important gender differences in their growth velocity and how they caught up or didn't catch up. So males and females did not differ in their stunting when they started ART initiation. But then at 10 years of age, significantly more of the females were stunted, not by a lot, but it's significant in the numbers, 40% of the females versus 34% of the males. But then the females have better subsequent growth, so that by the time you get to 15, more of the females have caught up. So only 25% of the girls are stunted at 15, and by 18, 15%. Whereas the males don't quite catch up over that adolescent time period. As one might guess, being older when you start ART, so starting your ARV medications later, and having a low CD4 count when you start therapy are associated with worse growth over time, with not being able to catch up as much of that growth. In addition, just to touch on, we see significant mental health and substance use issues among adolescents living with HIV as well. They have higher rates of substance use, mental health problems, difficulties in adjustment, and reduced emotional support. And this is particularly a challenge in a setting where there's a lack of provider training in mental health and disclosure support for adolescents. And this can especially be a barrier to transitioning them successfully out of pediatric services and into adult services. These mental health and substance use challenges may intensify during that transition. Then you see worse adherence, worse retention, and our care settings often lack coordinated services for mental health, of course, especially for adolescents. So this is really the guiding question of my own research career. How do we help HIV-infected children, adolescents, and their families sustain successful HIV treatment for their entire lives? The work that I've done specifically has ended up falling into these four pools around this: adherence to ART, supporting treatment durability, or how long we're able to maintain successful regimens, HIV disclosure, and then supporting mental health issues and addressing HIV-related stigma. Just to, I guess, summarize, and in part because it's sort of introducing myself to the group here, the work that we've done related to sustaining children and adolescents' adherence to therapy has included a conceptual model for pediatric ART adherence in East Africa, looking at how factors such as conflict, orphanhood, HIV disclosure, stigma, and mental health can impact children and adolescents' HIV care. I've described the work that we did to validate adherence measurement questions, and then we are following this cohort that examines adherence and viral resistance for over 600 Kenyan children who are on ART. With that, I've been able to play a role in participating in global HIV treatment guidelines and service delivery recommendations. I'm on the technical working group for that for the World Health Organization, and that's in large part because of the role of the IDEA Data Consortium that I've talked about, and how we're able to connect these global care programs for pediatrics and adolescents. We've also tried to look closely at how we might shape and support adolescent HIV care delivery more broadly with this. This has included not only developing ways to support adherence counseling, but looking at counseling interventions, including peer support curriculums, how we can support families through HIV disclosure, what kinds of educational and counseling support materials we might be able to use within the context of a fairly resource-limited care system to guide families in these challenges. We've developed an HIV stigma measurement assessment for households, and we're trying to figure out ways to then address HIV stigma in the community. In particular, right now I have a project going on that's using a multimedia curriculum with teachers to try to reduce classroom stigma for HIV. And then we've partnered in Kenya to build up an adolescent-specific health center in Kenya, again, trying to figure out how we might deliver more supportive services that can address these many challenges that we've looked at. I thought I would just show you a quick picture of this because it's a little bit more of a novel part of the work that we've done in Kenya. So our team in Kenya has an intervention strategy that we call Hadithi. Hadithi means story in Swahili. And in part we've used that because we want to help children and adolescents understand that HIV and learning about HIV is just one part of the story of who they are, that we don't want it to seem like the end of their story or the only thing that's defining them. But we've also used a narrative approach in many of the counseling interventions as well as the stigma reduction interventions that we've tried to move forward. So we've created a series of very short films, just a few minutes long, that have been used for disclosure counseling and adherence counseling. The films are available for counselors in our clinical system in Kenya to use and show families on tablets, and then they're accompanied by a counseling curriculum that includes prompts and questions to be asked. We also use them in our peer support groups as a way of guiding and supporting the peer discussions. And then we've created some slightly longer but still short films, about 15 minutes in length, that we've used in more of our community-based stigma interventions. So trying to use stories as part of how we guide families and shape how communities are thinking and feeling about HIV as part of this. We also have in our multimedia set of interventions an animation that describes HIV physiology using a cartoon that goes throughout, and essentially why adherence is so important and how resistance develops if you're not adherent. I mention this in particular because this animation was developed by a medical student. I've had for the last 10 years a one-year medical student research position with my research team, usually filled by a medical student between their third and fourth year of medical school. And one of our students during that time not only worked with our clinical research team more broadly, but she did focus groups and work with adolescents around how we might display and present this information related to how HIV and its treatment work in a way that's understandable, developed this animation, and it's now used widely across the AMPATH clinical system. So this is also not so secretly a pitch that I'm looking for next year for an interested medical student who, you don't have to be interested in developing animations, but who might be interested in working with our research team. I have a student funded through a Fogarty Scholar position through next May, and I'm always looking for the next amazing student to join our team. And then I've described a little bit in terms of my own work how I've found being able to collaborate in global cohorts to have incredible impact in what we're able to move forward worldwide. So as mentioned, I've been heavily involved with the IDEA Consortium. We also have in East Africa an adolescent cohort evaluation where we're following 400 some adolescents from across East Africa, care programs, doing more intensive behavioral and mental health assessments, as well as more detailed viral resistance measurement and so on for them. We're in the process of assembling a global adolescent cohort that would do these kind of prospective evaluations across the global regions of IDEA, and I am the coordinator for both of these adolescent cohorts. We have our cohort that we're following for resistance and adherence evaluations. And then our other exciting global effort, cohort-wise, is we're trying to put together a cohort of pediatric non-progressors or slow progressors, children who are able to maintain strong immunologic status and control their viral levels even without ART. We have to look at our historical data because our recommendations are now that all children are on treatment. But looking in those data, we've been able already to identify more than 1,800 children across our global cohorts who, in the era before everyone was on ART, were able to maintain high CD4 counts all the way into adolescence, greater than 10 years, without being on ART. Now that everyone's on ART, we're going back and finding these children and trying to put together what would be needed to assemble a cohort that could be studied more in depth. I wanted to highlight in our last minutes here the AMPATH program a little bit more, really as an example, and as we think about academic medical centers here. As I said, AMPATH stands for the academic model providing access to healthcare. It operates in Western Kenya, and again was born out of this partnership between two medical schools, the Moi University School of Medicine in Kenya and the Indiana University School of Medicine in the United States. It has subsequently grown much, much larger than its initial partnership for education, research, and clinical care. It includes the Moi Teaching and Referral Hospital, which is one of the two national referral hospitals in Kenya. It now includes a consortium of North American medical schools, which includes Mount Sinai. The other schools that are part of the consortium are listed there. It includes Duke, Brown, Hopkins, Purdue University, UCSF, the University of Texas in Austin, the University of Toronto. This consortium is still led and coordinated by Indiana University, but we're able to participate fully, and in fact, Mount Sinai is now the lead for the adolescent medicine research, clinical service, and educational opportunities within this consortium. The Kenyan Ministry of Health is a close partnership in this consortium, and then of course there's there's a larger group of supporters and sponsors for this work as well. AMPATH's motto is leading with care, and in fact it has evolved one of Africa's largest and most effective responses to HIV. Out of this academic partnership, the care program they've developed has been able to provide services to over 200,000 patients with HIV, including 15,000 children and adolescents. They provide free ARVs through PEPFAR USAID funding at over 800 clinical sites now. More than 1 million patients have been, or people rather, have been reached in home-based testing. And this has grown from an HIV care system into a much broader healthcare delivery system. There now are services for NCDs, oncology, a population health initiative, and that serves more than 4 million Kenyans. And this really includes Kenya's first system of a sustainable model for care and empowerment for an entire population. The Population Health Initiative of AMPATH includes pillars to provide economic support, an insurance package, and so on. This is just a map of the many AMPATH clinical sites across Western Kenya. And the AMPATH partnership model is one where, as I said, academic medical partners are really leveraging their strengths to advance care, to advance education, and to advance research, are three mutually beneficial goals within our academic medical centers. So the motto of AMPATH is start with care and then do more. So it's also been an extremely productive venue for research. There's been a commitment to collaborative, mutually beneficial research that improves care. In the AMPATH consortium, these 10 university partners have research partners as well. There are more than 100 active research trial protocols, a very robust research infrastructure that includes a clinical trials unit, grants management, IRB, and an electronic medical record system. The research program currently has $129 million in research awards, 80% of which is from the NIH, and more than 600 peer-reviewed journal articles. As the former director of this research network and having been responsible the last 5 years for its growth, I of course am proud as I present that, but mostly I present it here because it's an incredible opportunity for those interested in global health research to engage in a place with a lot of infrastructure and a lot of potential. And the educational opportunities that have been able to grow out of AMPATH have also been really significant. So there's been a commitment, and there's actually a requirement to commit in AMPATH to a bilateral exchange. In that bilateral exchange, more than 2,000 Kenyan and North American medical students, residents, and fellows have been trained through these global health opportunities. More than 100 faculty members from Moi University, and also from the North American partners, are doing training, caring for patients, and conducting research. And on a broader level, more than 1,000 community health workers have been trained to be an essential part of how services are delivered to provide health access across Western Kenya. Thinking of that economic empowerment and population health, AMPATH has tried to demonstrate how an academic medical partnership could move forward universal health coverage that includes empowering Kenyans to grow their own stable futures. So 30,000 group members have received training and support for income generation through AMPATH. They've organized farmer groups, which to date have sold more than 20,000 metric tons of food, and small savings and loans programs where community members come together in small groups committed to each putting in a small amount of money and then loaning it out among their group and repaying the group, have mobilized more than $5 million US through their own micro lending and saving groups. So there's been a lot of really interesting access to health, both from an economic standpoint as well as from the delivery of care services that we've been able to mobilize through this partnership. A few notes about the future. So I think AMPATH has a bright future. This happens to be a picture from Francis Collins visiting a few years ago, where he said the epicenter of medicine in the world is here in Eldoret. I like this picture on the right because he was taking a picture of the pharmacy, like with his phone, and he was particularly impressed by, this is actually a paper chromatography device that's been developed to detect counterfeit medications. You swipe a tablet across it, dip it in water, and based on the color pattern can tell whether active ingredients for specific drugs are present or not, and he was really excited about that. For adolescents, this is another paper of the IDEA group that came out last week, but as a quick note, we've seen incredible improvements in the initiation of treatment for adolescents with changes to guidelines that try to get all patients, all adolescents on treatment. So you having universal ART eligibility has significantly improved our adolescent treatment initiation. We hope that will continue to move forward. And perhaps most brightly of all, our future really is in our adolescents as well, as we try to move them into the adult world. The two on the left, these are two adolescents that have grown up in our HIV care program who are now peer educators who work with their peers to not only facilitate peer support groups, but also as navigators through the care system to collect them with care. And in the right picture, the two young men there have actually become part of our research team. Actually, we have, I think, 7 adolescents or young adults grew up in our care program. Oh my goodness, sorry, I just spilled the bottled water. Who are part of my research projects right now. And they, the two on the left actually developed an app that provides information on HIV and referrals to youth that they were presenting at the International AIDS Society in that meeting. So we're really proud of how they continue to develop. I'm going to stop there, and thank you so much for your attention today. Thank you to everyone for listening through this, and it's great to share with you. I got your system on the wet here.
Wonderful presentation. Thanks. May I ask you, where do you get the medications at the different levels? And is there a quality control that the purity of the drugs are the same everywhere?
Sure. So all of our, the funding for the medications that we've been providing for HIV care is through the PEPFAR USAID program entirely. They also provide the funding that supports the clinical services, which I should note is 99% provided by Kenyan doctors, nurses, and so on. There are only a few dozen Americans involved at all. They use national mechanisms for the medication supply channels, but we actually, Purdue University, who's part of our consortium of schools involved, has been involved primarily with a focus on pharmacy and on the control of both our drug supply chain as well as looking at the quality of the medication specifically. So the counterfeit detection projects that we've had going on have actually been largely related to antibiotics, antihypertensives, and so on. The supplies because in part it's standardized through the USAID procurement mechanisms, our ARV supplies have been fairly consistently decent. They've seemed to be of good quality that way. But we have essentially 3 tiers of regimens available for HIV care right now in Kenya. For our third-line patients, we actually have to apply on a case-by-case basis for them to move to a third line.
Yes, it's a fabulous fabulous demonstration of implementation science at its best. One question that I had is whether or not you've assessed the likelihood that adolescents might be happier with a single injection every 3 months. Now the studies with broadly neutralizing monoclonal antibodies raise the possibility of moving to that as a therapy and prevention. And I just wonder if the teenagers who obviously, this is like replaying the diabetes story in adolescence, but whether or not there's any data that might suggest that might work for a population.
There is. So we haven't done in East Africa, we have not done a specific study around preferences for medication formulations. However, I do have data from one of my adherence studies related to that question where they absolutely say they would prefer a long-acting injectable option. And I can say that the global data, especially from South Africa, where they've done a number of, and have also done some trials with even placebo formulations of these things, so actually testing out, like when it comes down to getting an injection, are you okay with that and so on? The youth have been, by and large, extremely accepting and, in fact, are begging for it. So we're very, very excited about the potential for long-acting options for ARVs, and particularly the injectables, actually. My kids are begging for them, honestly.
Dr. Sparrow.
Has there been any data on decreasing the duration of treatment necessary for treating HIV?
There have been, unfortunately, particularly for adolescents and children, we have not seen good results in some of our trials where they've tried to, for example, have like weekend times off of medicines or trying to go down a bit on the options. We also have, unfortunately, until you get to be a bit bigger and more adult size, your regimens are not as simple as they are now for adults, so they do often too end up with a greater burden of pills and so on. So unfortunately, unlike in the adult world where there has been some ability to simplify some of the regimens, both because of the size of many of our youth, as well as the limited regimens that we have available in most of the places where these youth live, we still have relatively complicated and frequent burden of medications, which is in part why, you know, having some of the long-acting formulations on the horizon is incredibly exciting to us.
I think we'll leave it there. Thank you very much. A wonderful
Thanks.
talk. Thank you.